The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss glioblastoma, a treatment and care update. My name is Jelan Demas, Senior Program Manager here at the American Brain Tumor Association, and I'm delighted to introduce our speaker today, Dr. Michael Vogelbaum.
Well, great. Thank you so much. It's really a pleasure for me to be here today, and hopefully I'll be able to provide you all with some useful information and some updates about some of the new developments that are occurring in treatment of glioblastoma. So just to start with a little bit of background about these tumors, there are about 500,000 U.S. residents who will be diagnosed with some type of brain tumor each year. Unfortunately, most of those are either benign tumors or others that are more treatable. But about 17,000 will be found to have a primary brain tumor, and these are most often going to be higher grade tumors that are difficult to treat. The majority of these primary brain tumors are gliomas, and more than 50% of those are the highest grade glioma or glioblastoma. Now, how do we classify gliomas? It's really by histology, it's appearance under the microscope, and that's a key feature. These are uniform and objective criteria that have been adopted by international agreement, and there was a conference led by the World Health Organization that helped to standardize this system. There are 4 grades that we describe for gliomas. And a higher number means a more malignant tumor. That said, it should be kept in mind that even some of the lower grade tumors, grade 2 for example, still are considered to be cancers. They are malignant. They're just much lower grade malignancies and have a much more favorable course than the higher grade tumors. The grade 1s are a separate group that are often surgically treatable and even curable. But for the most part, what we're talking about today are the ones that are grade 2, 3, and 4, which are diffuse and have various grades of malignancy. The grading is used to predict prognosis and to plan treatment. Another important point about understanding grades is that it's really a continuum. Some people who have had a grade 2 tumor are surprised when they find out that it's now a grade 3 or grade 4, but that is the natural history of the disease. Eventually, they for the most part, all progress. Grading can only be done on tissue, so either through a limited biopsy procedure or a more extensive resection, but tissue is required in order to determine the grade. Also important to note that all patients with brain tumors are going to undergo some form of scanning, either MRI or CAT scans. Often they'll hear from their primary care physician or from the radiologist that it looks like they have a tumor of a certain grade. Well, MRI and CAT scans cannot tell you what the grade is. Only histology can. They just are useful for predicting the grade. But even we sometimes are surprised where we'll see something that has higher grade features on MRI that may actually end up being lower grade. As I said earlier, gliomas progress over time. And so on the left is a CAT scan of a patient with a non-enhancing tumor when they presented. Unfortunately, later in the course of the disease, as is shown on the MRI, it became an enhancing tumor, and it was a higher grade tumor at that point. So how do we treat patients with brain tumors? Well, there are some basic principles. Number one, we have to establish a diagnosis, both of the type of tumor, that is a glioma, and the grade. Then we have to decide whether or not we can perform a surgical removal of the tumor bulk. And that depends upon a number of features that the imaging helps us to predict. For example, the type of tumor, whether we suspect that it is a truly benign tumor or something that is a malignant tumor or a glioma. The location is very important, and I'll talk about this a little bit later. Whether or not there are symptoms, and particularly if they're related to the mass of the tumor itself, and then the general health of the patient. There are also a number of medical treatments, and these are guided really by the type of tumor and the grade, and we'll talk about that as well. So with surgery, there are very basic goals. To make a diagnosis, if one is not already known. To maximize resection, at least of the bulk tumor, and most importantly, to minimize the risk of neurological deficits. And we have specialized techniques that allow us to accomplish all of these goals in most patients. Here we go. Specialized techniques. Well, this is where surgery started many hundreds of years ago. And at the Cleveland Clinic, we've adopted some more advanced techniques, notably the introduction of anesthesia right here. And of course, we wear these hats, which make us much more effective. But in reality, there are many better techniques than that in today's age. As I mentioned earlier, a lot of the decision-making about which techniques to use depends upon the location of the tumor. These MRI show examples of a different type of tumor, brain metastasis, that is cancer that's spread to the brain, but they illustrate the point that some tumors can be in very superficial locations just below the scalp here, and here as well, very close to the surface of the brain. And these are typically easily removed without any kind of specialized techniques, aside from the straightforward brain tumor surgery. In these examples, however, these are tumors that are located in highly functional areas. This one in the speech area, this one in motor area, and this one in the brainstem. And we have to use different approaches for those. And when we talk about the location, what we're really referring to is the functional anatomy of the brain. Really, when you look at the brain surface, it all looks very similar. But in fact, there are some discrete locations that have specific functions, including the motor area. Here, the somatosensory or sensory cortex. Here, there are speech centers typically on the left side of the brain, but in some patients on the right as well, and visual cortex in the back. And these are areas that we need to understand the relationship between them and the tumor and factor that into any surgical plan. And as I'll show you, we have some techniques to deal with this even when tumors are in or adjacent to functional areas. So how do we maximize resection and minimize risks? Well, patient selection based upon the same factors that I told you above, but also advanced surgical techniques, including image guidance, functional mapping, and intraoperative imaging. It has been said that the most significant advance in surgery for brain tumors in the past 30 years is the development of image-guided surgical navigation systems. It used to be that we would do a very large craniotomy, and that's the point behind that first statement. The only good craniotomy is a large craniotomy. That's what was said in the old days. In those days, we didn't have much to guide us. We had an MRI that we could look at, and our understanding of the anatomy that's presented on the MRI and how that relates to a patient. And even before that, we had fewer options. We didn't have MRI. We had angiography, pneumoencephalography. There was actually exploratory brain surgery performed decades ago, and other visual cues that we look for. And this is what a craniotomy would look like back in those days. It would be very large, and we'd have to use a number of visual techniques and some other instrumentation, including ultrasound, to try to find the tumor. This is what it looks like today. We can make what's called a minimal access craniotomy, a small opening directly over the lesion, and that makes for a much safer operation, a much faster operation, and it also allows us to improve our extent of resection. Image guidance systems provide us with localization, orientation, and target and trajectory guidance information. There are a number of advantages. We can make what we call limited footprint craniotomies or minimal access craniotomies. We can plan the safest trajectory to a deep lesion. We can tailor the extent of resection to respect anatomical and functional boundaries. As good and as revolutionary image guidance has been for brain tumor surgery, there are still limitations. One is that the brain shifts as we remove tumor material, and we are setting up our navigation system based upon a preoperative MRI or CAT scan. And if the brain shifts, then that what we call a registration set is no longer accurate. And there are things that we can do to try to overcome that, but there are some limitations. The second one is an old limitation. We actually can use any type of imaging data now. That is not an issue. This next image shows a series of MRI images taken intraoperatively during a brain tumor operation, and it illustrates the problem of shift. Start with the left-sided images. These are sequential images taken before the start of surgery. This is the tumor that's being removed, and this part of it is lighting up with contrast. This is the scalp surface here. Based upon this MRI, the operation then started. A little while later, about 3 hours later, an MRI was obtained to see what was left. And you can see now that the brain surface is shifted away from the undersurface of the skull because of the resection of a large portion of the mass. And over time, all the way out to even another hour later, you can see progressive shift occurring. And that means that our image guidance data from this point is no longer valid. It's not very useful. This is an older intraoperative MRI technology. We actually now use a newer intraoperative MRI technology. This shows our intraoperative MRI OR just when we were commissioning it. And so this is the OR table, and behind these doors is the MRI. And so the MRI machine, which is a very strong magnet and is not compatible with most of our instrumentation for surgery, rests back in that room while we're operating. We can operate with all of our normal instruments here, and then when we're ready for images, we move all the instruments out of the way, and then this MRI is on rails, and we can move it right in over the patient and obtain a new set of images. And this is what the images look like. You can see they're much higher quality. This is the preoperative MRI showing this tumor, and this is in the axial orientation. This is in the coronal. And you can see from about a cut here, that's what that point is. And then intraoperatively, we felt that we had removed most of the tumor, but we weren't sure. We obtained this image, and you can see there's a little bit of tumor left here. And then when we obtained our final MRI, after removing this portion, you can see that it was completely removed. What's that faint little bit of stuff there is just blood products. But there was no more tumor remaining. So this shows you the benefit of having intraoperative MRI. Now, there are some limitations to intraoperative MRI. Some systems have a requirement for MRI-compatible instruments. That is, if the MRI machine, if the magnet is nearby the patient the entire time of the operation. Other systems, like the one that we use, keep the MRI away from the surgical field while we're operating, and then we can move it into place when we need to image. And so we can use our normal instruments. The lower field systems, that's the magnetic field systems, may have limited resolution. I showed you our older system, which is a much lower field system, and you can see the difference in quality. There is an increased time to the procedure, and there may be surgically induced changes we see on the MRI, and so having experience with this is important. Now, all of this is directed towards trying to enhance the extent of resection of the mass tumor, which is our goal in surgery, at least one of our goals. There's another approach that's still developing, which I refer to as a low-technology imaging approach. As you might imagine, putting an MRI in the OR costs millions of dollars. It is a very high-technology approach. Another approach may be to use intraoperative fluorophores that can be used to document the presence of residual tumor. And so the principle behind this is the same as why we use contrast. So when we're doing an MRI, we give intravenous contrast, and the contrast molecule normally cannot get into the brain. But where there is a high-grade tumor, it can actually leak into the tumor because the blood vessels, at least microscopically, are not normal. Well, with a fluorophore, one can do essentially the same thing and allow it to leak into the enhancing tumor. And then fluorophore is something that will fluoresce under specific conditions, and you can detect it by looking for fluorescence. And that's the idea behind this one. This is something called 5-ALA. It is a precursor of heme, as in hemoglobin. It is a precursor of heme, and it is normally converted into another molecule called protoporphyrin 9. Protoporphyrin 9 will glow red when it is exposed to blue light. Normally, any cell will do this. However, tumor cells have very, very highly active conversion of 5-ALA into protoporphyrin 9. And because of that, we'll make much, much more of the protoporphyrin 9, and then the fluorescence can be seen visually. And that's the basis for using this. And in the bottom part of this figure, you can see a tumor in a rat brain, and you can see that it's glowing when exposed to blue light. So that's the idea behind it. How do we do this? We do it using an operative microscope. Microscopes are used like this. Surgical microscopes are used all the time for brain tumor surgery, and they can be equipped with a filter set that converts from white light to blue light at the touch of a switch, and then we can go back and forth between white and blue light for operating. So here is a typical intraoperative image. We have removed what we believe to be all of the contrast-enhancing tumor, and we're looking at the margin and asking ourselves, is there any tumor left? And I can tell you, looking at this image and having looked at this many, many times under a microscope, I don't know. I can't look at this tissue and tell you whether or not there's any microscopic tumor tissue remaining. However, when we switch to blue light, in this case where we use the 5-ALA, I don't know how well it comes across on your screens, but there is red fluorescence here, which was obvious under the microscope, and we removed this to remove that portion of the residual tumor. Now, 5-ALA, as interesting as it is, remains investigational in the U.S. It is approved and in use in Europe, but it is not yet widely available in the U.S. The FDA has not approved it yet. There are some efforts to start a registration study, but that is not yet open. And any use of it in the U.S. has to be done under what's called an IND, which is applying to the FDA for permission to use it in a small study, and that's what we're doing here. There are some other fluorophores that are available, but they're not yet in widespread use, and for the most part, they don't seem to be as tumor selective, or they're not as tumor specific as the 5-ALA appears to be. Now, as I said earlier, it's really important for us both to get as much of a resection as possible, but also not to go too far, not to cause new neurologic deficits that are irreversible. So how do we know when to stop? There are a number of techniques that we have to do that. We have our basic understanding of the anatomy of the brain, but everyone's anatomy, when it comes down to millimeters, is different. And millimeters mean a lot to us, and we don't want to go too far in one direction or another. So we have a number of techniques to try to determine where functional areas are in each individual patient's brain. And we can start with imaging that we can do before the surgery. So here's an example of an MRI with a tumor in an area that we would suspect to be involved in language. But we want to have some more information about that. And there are some preoperative imaging studies that we can do to try to assess that. But ultimately what it comes down to is performing functional mapping in the operating room. The preoperative imaging studies, including a functional MRI, are predictive in nature. Ultimately, our gold standard is doing what's called electrocorticography in the operating room, as well as doing monitoring as we operate. And this is what we refer to as awake surgery. So this is a tumor in a functional area. We placed a set of electrodes that are going on the surface of the brain. We actually slip them underneath the lining of the brain, the dura here, and we can map this entire area while the patient's awake and doing language tasks. We have a neurologist helping us in the OR. They're monitoring the EEG and giving us information about what's going on in the brain there, and plus we can stimulate and evaluate the patient's function. And with that information, we can determine different areas and what their functions are and decide where we can operate and where we can't. This tumor we found was there was no functional area right here, so this was our path to the tumor, whereas there was function all along here, and we were able to remove the tumor, and the patient did not suffer a neurological deficit as a result of that. So why do we try to perform complete resections? Well, it would seem obvious that we want to take out as much tumor as possible. I'm going to show you in a moment why we can't cure GBM with surgery alone. However, we have very good evidence that indicates that removal of all of the contrast-enhancing material is associated with a better outcome, a better survival. And this is why we do it. So here's an example of a patient with a tumor in a horrible area of the brain. Horrible because it is adjacent to important speech areas, and it's in an important cognitive area, and this is what it looked like at diagnosis. And then 2.5 years later, well, this was a GBM, and the median survival for GBM is only about 1.5 years. And here's this patient 2.5 years later, and functioning independently and having an excellent quality of life. So in this case, I think we really helped the patient. I wish we could help every one of them like that with the surgery. Unfortunately, that's not yet the case, and I'm going to talk about where we're heading. In some patients, a surgical resection is not safe, even with advanced surgical techniques, but we still have to obtain tumor tissue for diagnosis because treatment choices depend heavily on the exact type of tumor, and this is where we can use our stereotactic guidance systems to perform a biopsy only. And this just shows you an example of a trajectory that we could use to get to a deep brainstem tumor. Now, there are other surgical techniques that are being used when an open surgery is not possible. Stereotactic radiosurgery is one that is commonly talked about, and a number of centers do it routinely. Unfortunately, it's not yet been shown to be effective for gliomas. In fact, there was a large study for GBM that showed that not only was it not effective, but it was associated with a higher risk of complications. So the risk outweighed the benefit in that case. So this is something that we do not do routinely here. It is an effective alternative to open surgery for other types of tumors, but not for GBM in most patients. There is another type of novel treatment as well, which is called laser interstitial thermal therapy, or LIT. And one of the devices used to be referred to as autolit. It's now called NeuroBlate. And this is another alternative to open surgery for tumors that cannot be removed safely. The background behind that is that you use laser energy to selectively coagulate tumors with interstitial hyperthermia. It's minimally invasive, it's MRI guided, and actually we can use the MRI to monitor temperature in real time. And I'm just going to give a little bit of background about it, and that is we know that heat can kill cells. Of course, we know that in general, but the amount of heat can be controlled carefully, and depending upon the amount of time that cells are exposed to a certain amount of heat, you can actually have selective death of tumor versus normal tissue. Also, there's this technique called MR thermometry. You can use MRI to measure temperature, and this is just an MRI of a knee, but it shows that we can actually measure different temperatures in the region just using MRI imaging alone. And this can also be done in the brain, and this is an MRI actually of a pig brain showing that you can measure temperature as the laser interstitial thermal therapy is being performed, and you can see that in real time. With this delivery of heat, over time you actually have temperature changes, and you can make predictions about the probability that the tissue within a certain region is going to be effectively treated by that temperature. And so you can predict where a damage area is and then where the intermediate boundaries are between an effect and no effect. And that's the basis behind performing LIT. Now, in clinical practice, this is what a case may look like. The upper images here show preoperatively a recurrent tumor that was treated with LIT. And the outline shows essentially where the temperature change occurred that was predicted to have the therapeutic effect. As soon as 24 hours later, you can see there's loss of contrast enhancement in this area, which is a good sign that, that the therapy is working. And now you can see the changes over time from day 1 to day 180, and you can see that not only was there the loss of contrast, but it seemed to be quite persistent. So it seems to be a very effective treatment in that particular lesion over that period of time. So what are the future directions for surgery? Well, most everybody comes to me asking whether or not we're going to use robots to do the operation. And I have to say that for now, quite fortunately for me, I don't see that I'm going to be replaced by a robot anytime soon. The surgery is rarely curative for malignant brain tumors. It can improve survival and quality of life. It can help monitor the effects of treatment. But this slide illustrates why it is not curative. All along I've been telling you about removing the enhancing part of tumor. That's the part of the tumor that on MRI lights up with contrast. And this is essentially confluent tumor. So if you look at this schematic of what a histology slide will look like, this will be pure tumor cells in this area. And that's what we can remove with surgery. But we're kidding ourselves if we think we're going to cure the disease, because actually when you look at this MRI, this shows more the extent of the infiltrating tumor around that tumor mass. And if you do biopsies in these areas, you'll see infiltrating tumor cells even a great distance away. And so removal of this area does nothing for the disease that's in these areas. So we have to look for other ways to try to treat the residual disease that is there after surgery. And that's why treatment also consists of radiation therapy and chemotherapy. Now, radiation therapy has been shown for many, many decades to be an effective treatment. Chemotherapy has been much more controversial. There are a few chemotherapies that can get into the brain when given by conventional routes, either intravenously or orally. There are techniques to try to improve drug penetration into the brain that are being investigated, but these are still experimental. One of them, for example, is blood-brain barrier disruption, which can break down the barrier which keeps the chemotherapy out, and appears to be a nice treatment option for one type of tumor in the brain called CNS lymphoma, but has not yet been proven to be effective for gliomas. Another approach is convection-enhanced drug delivery, where drug is actually pumped into the brain, and I'll show an example of that. And that also remains an experimental technique at this time. And here's an example of convection-enhanced delivery. Now, in this case, there was a catheter placed into the brain, and then a drug was pumped in along with a substance that emits a small amount of radiation that can be detected on a scanner. And so over time, you can see where this drug has spread, and it looks very nice. Unfortunately, a couple of large trials that were initiated failed to show a therapeutic benefit so far with the drugs that were investigated. But there's a lot of research being done to try to improve that approach. So this is still a work in progress. As I said, the clinical efficacy has not been demonstrated. But this may be due to limitations in technique and technology, and there's a new generation of devices in clinical trials now in development. And this is one of the trials. This is a trial that we're doing with CED, and in this case we're delivering an experimental viral vector therapy. Here you can see MRI images from the procedure over different times where we're injecting the therapeutic vector into the tumor here, along with a little bit of contrast that we're injecting in at the same time directly into the tumor. And you can see that the contrast starts to appear and expands to fill the area of the tumor. This is done in the MRI environment with specialized devices that allow us to target effectively where we want to deliver this. So this is very interesting experimental work that is in progress. Now, what about medical treatment? Well, as I mentioned earlier, for decades, radiation therapy has been the mainstay of medical treatment. Doses are given small fractions to allow normal tissues time to recover between the doses, and that's why the treatment is done over a 6-week period. The standard scheme involves a highest dose to the tumor core, this area here, followed by reduced doses to the surrounding brain to have an effect on the tumor cells, but to minimize the effects on normal functioning tissues in these areas. And the total dosing is set to maximize the effect and minimize side effects. It's always a balance. There are studies that were done decades ago that showed that you could go much higher in the way of dose and see more efficacy, but the cost was too high. Radiation therapy is used for all glioblastomas, grade 4 tumors, and for most grade 3 tumors as well. For grade 2 tumors, the use of radiation therapy is more individualized, and there are a number of investigational studies that are looking at this. Large studies have shown that delaying radiation therapy has no impact on survival and can be given in a delayed fashion for those patients. But really what we're talking about here today are the grade 4 tumors, and they all need to receive radiation therapy. As I said earlier, radiosurgery is favored as a technique that can deliver much higher doses to targeted tissue. However, a large, well-designed trial showed that radiosurgery added no survival benefit for patients with newly diagnosed GBM and increased the severity of radiation-related complications. So we really reserve this for very, very unusual cases or where we're running a clinical trial to see if we can try to improve the technique of radiosurgery for these patients. Chemotherapy, as I said earlier, for many decades the use of chemotherapy was controversial. Often it could only be delivered by intravenous route. The side effects could be permanent, usually given only after radiation therapy, and as I said, few chemotherapies get into the brain by conventional routes. In the U.S., most patients were treated after radiation, but in other countries they were not. That was until we found that temozolomide, which is an oral chemotherapeutic, showed increased activity against gliomas. And what's advantageous about this is that it is pill form, so it can be given orally. It's much easier to give it daily than it would be for an IV. It has more reversible side effects, and it has better brain penetration than many other chemotherapies. There was a very large European study done that combined temozolomide with radiation therapy and then continued temozolomide after, and it showed a clear improvement in survival compared to radiation alone. In fact, the 2-year survival for GBM patients increased to 25% from 5%. And as much as remarkable of an improvement that is, it still shows that we have a long way to go. The newer chemotherapies are referred to as targeted chemotherapies. These are drugs that are designed to block specific cellular pathways as opposed to traditional chemotherapies that poison the most rapidly dividing cells, and temozolomide or Temodar is one of those types. Many of the new ones are referred to as signal transduction inhibitors, and gliomas seem to be ideal targets because they have their growth signal pathways overstimulated, and there are multiple targets that have been evaluated with mixed and inconclusive results, this is very complex biology that we are learning both in the laboratory and in the clinical studies. And also, many of these new types of drugs may not reach tumor cells for the same reasons that some of the old chemotherapies didn't either. I mentioned how important it is to get tissue for diagnostics. I'm going to give you another reason why tissue is so important. It helps us learn more about the disease. It helps us find new targets to treat. With tissue that we obtain from surgery, we're able to do complex genetic and genomic analyses that generate maps that look like this. Now, this is somewhat indecipherable, except that it helps us to identify different classes of tumors. That's what the M1, M2, M3, and M4 refer to. These are a multitude of genes that are being evaluated in a multitude of tumors, and we can group them based upon the signatures of the genes that they're expressing. And this helps us define groups which are distinct from each other. These are all GBMs, but in fact we can define them as distinct groups genetically, and that helps us not only for prognostics, but to determine new targets that we can attack and start to develop personalized therapies for patients with GBM. And so we cannot do this kind of work without tumor tissue that's available for research studies like the one I showed you there. So with targeted chemotherapies, I told you that we can block specific pathways. I'm going to give you an example here, and that is an anti-angiogenesis strategy. So in order to grow, tumors must form new blood vessels to receive the nutrients and oxygen that they need. And there is a protein that helps drive new vessel growth called VEGF, or vascular endothelial growth factor. It's a very potent stimulator of new vessel growth. There's a drug you may have heard of called Avastin, or bevacizumab, that removes VEGF from the circulation. VEGF freely crosses from the brain to the circulation, and the VEGF, the Avastin that is in the circulation, essentially acts as a sponge and removes that VEGF, and that takes away the signal for growth of new vessels. And that's the idea behind it. In several studies in patients with recurrent GBMs, Avastin helped to reduce the volume of the enhancing tumor. It reduced the amount of swelling in the brain, and as an aside, VEGF used to have a different name. It was called vascular permeability factor. Before it was understood to drive new blood vessel formation, and it was actually found to be a driver of brain edema. And it still has that same function, even though the name has changed. So Avastin, which removes the VEGF, actually treats both the edema and it helps reduce new blood vessel formation. The studies have shown that Avastin increased the time until tumor progression. Whether or not it has increased survival is still an open question, and there are some prospective studies that are being reported on where the final results will determine whether or not it really does have a benefit for survival. But it seems to have a strong symptomatic benefit. Downsides to Avastin, well, it can only be given by IV. Fortunately, it does not have to be given daily. It's typically given every 2 to 3 weeks. It does actually increase the risk of surgery. So we do not typically do surgery within 3 weeks of a dose of Avastin. It does have some other risks, including blood clots, which can go to the lungs, and some patients can have problems with blood pressure control. But in terms of treating symptoms, it has been a very nice option. Other new treatments that are being developed, immunotherapy, multiple approaches have been investigated, and there are trials that are ongoing. All of us would love to find a way to ramp up the immune system to treat GBM, but those investigations continue. There's a lot of excitement. We do not yet have data showing that they are truly effective in a large group of patients. And then gene therapy, trying to introduce genes into tumor cells that render them susceptible to treatment. Multiple approaches have been investigated. We're learning more with each of those trials. We feel like we're getting closer to these being effective, but they're still investigational. So how do we find cures? Well, ultimately, cures come from research. They come from investigations into the basic mechanisms of glioma formation, growth, and resistance to treatment. And these are laboratory-based studies usually conducted in hospitals and universities, most often not by drug companies, although there are some exceptions for early-stage drug development. These are studies that are funded by NIH, American Cancer Society, and very often by individual donations, also by organizations like the American Brain Tumor Association. This is essential for us to be able to move forward, and this research very often focuses on tumor tissue that we obtain from the operating room. Here we always ask our patients if they're willing to allow us to use the tumor tissue for laboratory research studies, and I would say that 99% of the time we're given permission by patients to do that. We think that's essential to being able to figure out how better to treat patients today and in the future. Also, cures come from development of new devices and new drugs. I showed you one recently developed device, which is the Autolid or NeuroBlate, which seems to provide benefit to patients, and then other ones that we're helping to work on here with convection-enhanced drug delivery, and of course all the new drugs that are going through evaluations here and elsewhere. ultimately, these new drugs and devices have to be evaluated in clinical trials. We cannot ever prove these to be safe or effective without evaluation in patients. Also, most of these things cannot be used in patients unless they're being used in a clinical trial. All new drugs, all new devices are regulated by the FDA and also by local hospital IRBs, or institutional review boards. And they mandate that clinical trials must be reviewed and approved before they can be done. Unfortunately, only about 5% of eligible patients choose to enter clinical trials. So if we want cures to come faster, we need patients to understand what role they play in helping to advance our ability to treat this disease. So in conclusion, GBM remains a deadly disease. Although we've made some advances, survival still depends mostly on histology and molecular genetics, age, neurologic functioning, and extent of resection that can be performed. We have multiple surgical tools that can be used to optimize our ability to provide a maximally safe resection. Medical therapies are providing greater survival benefit than ever before. That said, cures still remain elusive, and really we need to do additional drug device development and evaluation in clinical trials to get to our goal. Treating patients with GBM, doing research, trying to advance the field requires a large multidisciplinary team. I'm very fortunate to work with a team like that, and a team that I consider to be the best team, and we are here to try to provide the best care possible and also to advance our ability to treat patients with brain tumors. Thank you, and I'll be happy to answer any questions.
Thank you, Dr. Vogelbaum. That was excellent. We will now take time for questions. Just a reminder, if you have a question you'd like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of our screen. We have some already here. Okay, the first one is a question about how far away are we from human testing for small interfering RNA?
So that's an excellent question. So this is a new aspect of tumor biology that is still being investigated. These are small segments of RNA, which is part of the genetic code, the messenger part of it, that actually will block expression of certain genes, and we can identify clusters in tumors that seem to be associated with certain biological patterns, and may also be targeted to try to alter, to effectively treat tumors, alter their behavior, make them more sensitive to treatment, or more directly treat them. These still are largely a research tool. There are several issues with these types of molecules. One is that introducing them into the tumor may be difficult. It may not be so straightforward just to administer them in an IV form, for example, and get them to the tumor. So ultimately it will be a delivery problem. There are a number of other issues that are very basic to drug development in terms of developing forms of these molecules that are stable, that can be given in a predictable manner, and that can be administered in a hospital or an outpatient setting. These are basic issues that drug companies have to deal with all the time. So we're still a ways away. I think we're still really focused on the biology of these interesting molecules.
Wonderful. Someone is asking about how effective the Gliadel wafer is.
Gliadel is, let me just explain what it is and then discuss it briefly. Gliadel is a biodegradable wafer which contains a chemotherapy called BCNU. Before Temodar, BCNU was one of the only chemotherapies that was available for brain tumor patients that had some reasonable success, and normally BCNU is given intravenously. The idea was to place BCNU into a wafer that can then be placed into a surgical resection cavity and slowly release the BCNU over approximately a 2-week period. This Gliadel was initially approved in around 1995 based upon a single randomized study that showed some modest efficacy. And then it was actually, that was in recurrent GBM, and then its approval was extended to newly diagnosed GBM based upon a European study that also showed some efficacy in newly diagnosed GBM. For many, many years, Gliadel was the only real way to deliver chemotherapy directly into the residual tumor because we didn't have other chemotherapies that could get into the brain quite as effectively. And that changed with the trial that showed that temozolomide with radiation therapy was more effective than anything we had done before, and more effective than radiation therapy alone. Gliadel requires a complete surgical resection of the enhancing tumor for it to really be of any realistic chance of having an effect, because the release of the BCNU really allows it to penetrate only a few millimeters from the resection surface, and if there's bulk tumor there, it's not going to get very far, and there will be still untreated tumor behind that. It also, there are some risks associated with it in the way of infection and swelling. So for the most part, it is not being used quite as much as it was in the past, even though it is a perfectly acceptable treatment. It's not being used as much in the past for a number of reasons, in part because we believe that the temozolomide with radiation is probably more effective, and also when that is used as a treatment, it qualifies as a prior chemotherapy. And for many of the cutting-edge clinical trials of new treatments, there are restrictions on the number of treatments that can be given for someone to be eligible for the trial, and so often it's decided not to use that and to use other things instead.
Thank you. There's a couple different questions about complementary therapies and the ketogenic diet. Can you speak to those?
Well, I can only give very general answers there. I don't pretend to be an expert in the specific diets that are used to treat cancer. I know that all through my career, I've had patients ask me about that. I've had patients who've gone on to some of the diets, including ketogenic. We don't have clinical trials that show that these are more effective than any other typical diet. So it's very hard for me to be able to say with any certainty that they're more effective than just a reasonably nutritious diet.
I'd just like to interject that Dr. Mary Hardy had done a presentation for us last month, so if anyone wants to know more information, it's not specific to glioblastoma, but it's available at our website under our Anytime Learning section. So someone is asking a question about why interferon is not more widely used.
Oh, interesting question, because it is widely used in Japan. So why is it not used in the U.S.? And the short answer is we don't really have, we're not convinced by the data that it is provides substantial efficacy, and there certainly are a lot of side effects associated with it. And interferon is used for other types of cancers. Most patients who are on interferons don't like being on them, and without evidence that is suggestive of a more beneficial effect, in the U.S. we've not been terribly excited about using it.
Perfect. And there was a second part of that question, and I can answer that. People are asking about clinical trials. We do offer a clinical trial matching service here at the American Brain Tumor Association. For those of you that wrote in those questions, just give us a call on our care line, 1-800-886-2282, and we can connect you with a clinical trial specialist. There's a couple questions too about methylated and unmethylated. How would someone ask for that testing? Who would they go to?
Well, ultimately, that type of test, and what they're referring to is the MGMT assay, and MGMT is a gene which codes for a protein which is a DNA repair protein, and chemotherapies such as temozolomide act by injuring DNA that's being reproduced, which is most likely to happen in a tumor, which is why it's used for that purpose. MGMT is a protein that can help repair that injury and is a form of cancer resistance. And it's known that some tumors actually lose the ability to generate MGMT, and it's thought that that translates into more sensitivity to chemotherapy, although that's still a bit of an open question. That said, we know that those tumors that do not make the MGMT, often that's a signal for a better prognosis. And so that's the methylated versus unmethylated. Methylated refers to a change to the gene that allows it to be expressed. So the methylated ones are not expressed, the unmethylated ones are. So when we talk about that testing and whether the MGMT is methylated or unmethylated, that's what the test looks for. The testing has to be done with on tissue. It requires a good amount of tissue, and it has to be done with a physician order in order to do it. There is a company that is currently doing the test commercially, and that could be sent by your physician to the company for testing. Also, some medical centers have their own assays that they do routinely. We have one here that we do that has a slightly different technique, but we believe gets at the same information. Now, the important thing to understand about the MGMT status, though, is that as far as we understand it today, it really only predicts prognosis. In terms of it predicting response to therapy, that's still very controversial. And there are a lot of other changes that occur in a cancer cell that has methylated MGMT. That's not the only gene that gets methylated. There are many others that do. And so it's a more complex picture than just a cause and effect.
Okay. A couple questions also about Avastin, wanting to know how long it can be used, and is it saved for only use after Temodar has been used?
Well, I'll answer the second one first, and that is it only safe after Temodar? Well, no. Actually, there are two large clinical trials that looked at it in the newly diagnosed setting, where it was used in combination with the initial treatment. The bottom line is that the use of it was not really a problem. The real issue is, was it really effective? So far it appears that we're not seeing enough signal from that. We're not seeing enough benefit to consider that to be truly beneficial from a survival standpoint. In some patients, there may be some risk associated with it. So no, it does not have to be used only after Temodar. However, the way it is currently approved in the U.S. by the FDA, that is in the setting of recurrent GBM, and in general that means that they've already received Temodar. The other question is, how long can it be used? So I'm not aware that there is an a priori upper limit to it. I think that that's certainly, there's nothing that dictates how long it should be used. Often, because there are side effects with any medication, we'll use it to maximal benefit. If someone seems to have stable disease after a very long course of it, then the question becomes, do they need to have this anymore? There is some concern about what happens if you then stop the Avastin, but in reality, that's not been a major question because we're not. Unfortunately, we're still not seeing people who live quite that long for that to become a major issue. So often it may be stopped because there's progression, and even then there's some thought of continuing it during progression because of side effects associated with stopping it.
Okay, I have time for one last question. Someone is asking about Valsite, if I'm pronouncing it correctly. Do you have any comments about that?
Sure. Oh boy, that's the hot topic right now because there's been a lot of interest in whether or not CMV, the CMV virus, is either responsible for GBM or in some way influences the course of it. And there's some interesting data that were published suggesting that treating with an anti-CMV therapy may improve outcome. One has to understand that that is a single institution experience. There is some controversy about it. It is a very exciting question. And there are other investigators in the U.S. who have been looking at this sequentially over a number of trials analyzing whether or not CMV is present. I can tell you that I'm part of a group that is trying to put together a larger trial in the U.S. To look at this. I'm sure that there are others looking at the same thing. We certainly want to investigate this in a way where we can have confidence in the data and know whether or not there's truly a benefit. This is going to be an important clinical trial. If it can be launched in the U.S., it will be a very important clinical trial. It is going to be one of those trials where patients are randomized, and patients are going to have to agree to do that if we want to get the answer here, because truly there are very compelling arguments on both sides, both for a benefit from that and against it being an issue at all. And so we need to answer that question, and patients are part of the answer here.
Great. That's all the time we have for questions. Thank you for joining us, and thanks again to Dr. Vogelbaum, Associate Director of Neuro-Oncology Clinic at Cleveland Clinic, also Professor of Surgery at Case Western Reserve. He's also board certified in neurologic surgery. We're going to pause for just a moment to conclude the webinar recording.